everything looks normal. That's the message most people get after their yearly physical. Labs are ordered, blood gets drawn, results come back, nothing is flagged in red, and it's considered fine. But think about what actually happened there. The lab report will flag the numbers that fall out of range. And now the health systems are built to move fast. The report gets a glance from whoever happened to be in the room that day, and they're skimming it through looking at, is it flagged, is it red, and that's it. But here's the problem. Diseases don't start when the numbers flagged red. They usually start months or years earlier, when the numbers are still technically normal, but significantly changing from the last time it was checked, a year or 6 months before. And it's heading somewhere you really don't want it to go. And that's not a red flag, but it's a trend. And nobody catches a trend in a single report or glance. Which is the whole reason why I practice this way. I don't wait till your labs turn red. Because by the time the numbers turn red, your disease had a running start. And the signal was there a year or two earlier, but someone just needed to be there watching for it. And getting ahead of it, start with which test gets ordered in the first place. Because you can't track a trend for a lab that was not ordered. Here's just one example. There's a blood test for one of the most dangerous inherited heart risks, and you only need it once in your entire life, and almost nobody gets it. Stay with me, and I'll tell you exactly what it is. I'm Dr. Safa Shiari, board certified in internal medicine and obesity medicine. And I believe that being strong, sharp, and independent in your 80s isn't luck. It's a plan, and it starts now. A standard physical would run a handful of labs for everyone, dictated by what your insurance covers rather than your actual risk. So I built something different. A 3-tier screening strategy. Core labs for everyone, targeted tests based on your story, and the cardiovascular test the standard system skip entirely. And then I rate them as trends over time against your history, not a one-time snapshot. Stick with me, and you'll walk away knowing exactly what to ask for in your next physical, and why each test could be the difference between catching something early and finding it too late. Let's get into it. Before we get into the labs, let me show you what normal could actually be hiding. Because these aren't rare or exotic conditions. These are ones I see every month. A blood pressure that's slowly climbing up, and it's caused by hormone problem that nobody has checked. Kidneys that are quietly losing their function before you feel anything. And I can't tell you how many patients I have that when we have our first physical, I tell them, hey, your kidney function has been declining over this many years, and they're shocked because nobody had told them about it. And though they have no symptoms, that is actually the golden time to introduce intervention to prevent it from getting worse. Whether it is diet, it is over-the-counter medications to avoid, it is how we are aggressive with our blood pressure management, or ordering some extra tests that tells us when things are starting to progress. And the difference is from going 10, 20, 30 years or dying with that disease versus having that progress to a point where quality of life is significantly affected or people die from it. Or a slow trickle of blood into your intestine, whether it's from an ulcer in the stomach or it is from a colon polyp or worse, and it shows up as anemia and it creeps in gradually. And if it's not caught, we might catch it when it's a fully blown problem causing intestinal obstruction, perforation, and it could lead to a big health event, hospitalization, and ICU stay that could have been easily diagnosed and treated to avoid all that. Or the thyroid starts to fail. It is very common in younger women, and it could start long before we can see fatigue, hair loss, significant weight gain. That could take months or years to reverse. Or cholesterol panel that looks fine on paper, but hiding an inherited risk that could put you on track for a heart attack decades earlier than your peers. Every one of those could sit inside a normal looking result, 0 symptoms. You feel fine, and the only way someone catching them is by ordering the right test, then reading them as a trend, not a snapshot in time. So here's how I actually do that in 3 tiers. So we'll start with tier 1, and these go for every patient every year, regardless of how good you feel. Each one is hunting for a category of silent diseases. So we'll start with CBC, your complete blood count. People think this is routine, but it's not. Your CBC is how we catch if you're bleeding into your gut, a stomach ulcer, a colon cancer, before you'd even notice or start having symptoms and complications from these illnesses. It catches anemia from malabsorption, celiac disease, or heavy menstrual bleeding. It catches if your platelet counts is too low, which puts you at risk of bleeding, or it's too high, which puts you at increased risk of serious blood clots. And it catches if your white blood cell count is too low or too high from different types of blood cancers. So blood count is not just a box to check. It's a cancer, clots, and bleeding screening. And it also hints us to certain deficiencies in vitamins or minerals. Your BMP, basic metabolic panel. And this usually includes your kidney functions, glucose, and electrolyte. It is how early kidney disease gets caught, while we still can do something about it. It has the first clues for where treatable causes of high blood pressure might show up. And it drives almost every medication decision that is made for you, because a lot of these medications gets cleared up by the kidney. And if there's decreased kidney function, then you might have toxicities or side effects from certain medications. And there are some medications even over the counter that could worsen the kidney function rapidly. And you can see how dangerous that can become when you don't have that information. So I can't prescribe safely without knowing what your kidney function is. The lipid panel, your cholesterol and your triglycerides, the raw material that builds plaques in your arteries. But here's the key. The lipid panel is just the starting point. It tells me whether we need to go deeper, which we will do in tier 3. Your average blood sugar over the last 3 months, prediabetes, years before the symptoms. And catching it in the prediabetes stage, we can still make a difference and turn it around. And this is one of the highest value things we do in medicine all around. Prediabetes increases your risk for heart attacks and strokes. So even though you're not in a diabetic range, where the cutoff was made initially because of that's when the risk for eye disease actually climbs up very significantly, the heart disease and stroke risk starts going up with the prediabetes. So it's not harmless. Now, if you're already in your 70s when this starts, then we watch it closely before stepping into any medication because the risk in treatment is different by age. So it's not one size fits all. And liver function tests. This come with conditions attached. So if you carry extra weight, you drink alcohol, you take supplements, especially those that have herbal components, or you like to use medicinal teas, or you're on certain medications or had certain issues before, I'll be checking your liver. Because metabolically associated liver disease is very common, and it's almost always silent until it's very advanced. The whole liver does the same job, so the damage has to be almost like you lost 80% of your liver function before things are really bad. And catching that early, reversing it, makes a huge difference for your health. A quick thing before we go to tier 2, you don't have to memorize any of this. I put all 3 tiers into a free checklist that has the lab when I order it and what it's looking for. It's linked in the description below. Okay, we'll go to tier 2. Now tier 2. So these are tests I add when your story calls for them. Your symptoms, your history, and your risk. The skill here is not ordering everything on everyone. It's knowing exactly which test is going to change what we do. TSH, your thyroid hormone. Now, every single cell in your body needs the thyroid hormone to do whatever function it needs to do. So if it's running too low, everything will slow down. If it's running too high, everything will get overworked. I do check this test on younger women, especially with family history of thyroid conditions, because there's a very common autoimmune thyroid condition, which is called Hashimoto's. And the symptoms often start very gradually that people don't realize that there's something happening until it's very severe. I also check it on anybody who has fatigue, headaches, hair loss, weight gain. An underactive thyroid could masquerade as stress or just aging for years. Ferritin, your iron stores. One of my pet peeves when people order iron panels without ferritin. We need it for diagnosis and we need it for treatment. So I check this when there's fatigue, hair loss, headaches, or heavy periods, or when we're treating anemia. A low ferritin tells me you're either losing blood or you're not absorbing iron. And then the real job starts to find out why. And I gotta say for ferritin, what labs flags as normal is usually referring to severe iron deficiency. And a lot of time when we have the symptoms I mentioned, we actually aim for higher levels. So a ferritin of like 50 will be normal. But when I'm looking for a cause for hair loss, fatigue, or headache, I'm going to want your ferritin to be between 70 and 100. Now B12. I'll check it for numbness, tingling, fatigue, fogginess, and headaches. B12 deficiency causes nerve damage that is completely reversible if we catch it early. So when symptoms fit, I check. And again, just like the ferritin, when we are treating the specific symptoms, we might look at higher levels than what is flagged by the lab. So when you have any of these symptoms, I would want your B12 to be above 600. Vitamin D, I aim for, while the lab will flag it deficient if it's below 20. Now, the reason why I go for this is I'm looking for long-term bone health. So most of the study we have about vitamin D, they look at mortality risk. So that level of 20 might be okay for not having a heart attack or stroke, but I haven't seen any studies that look at if you run with borderline low vitamin D in your 20s, 30s, 40s, how does that reflect on your bone density in your 60s, 70s, 80s? Another thing to keep in mind is vitamin D is fat soluble, so the more fat mass we carry kind of dilutes the amount of vitamin D we take, so people might need higher and higher doses, and I have people who need just 1,000 units versus people who need 7,000 units a day to keep it at a good level. And it also can lead to toxicity. I have a few patients that get carried away and take too high of doses of vitamin D, and that's not good either. So if you're taking a supplement, I'll check it. Urine protein. For anyone with diabetes, high blood pressure, or kidney disease, protein leaking in your urine is one of the earliest signs that your kidneys are under stress. And if we catch it early, we can actually slow it down and push the brakes on progression. Now, PSA, or prostate-specific antigen, is a blood test for screening for prostate cancer. And we usually order it for men starting screening at 50, unless they have family history, which might require screening earlier. And PSA is one of the greatest examples why screening is a clinical judgment. The blood to draw is easy. The hard part is what you do with that number. When to repeat it when it's actually concerning, and when to refer to a urologist. Done thoughtfully, it catches prostate cancer early and saves lives. Done carelessly, it could lead to unnecessary biopsies, visits, tests, and a lot of anxiety. And that test deserves a real conversation. And now this one, it's very rarely to have a doctor who would talk about that. It's called Cystatin C. I order this for a specific group. If you have a large muscle mass or you take creatine supplements. And I do recommend taking creatine as a supplement for a lot of my patients. So this comes up. Here's the issue. Your estimated kidney function, the GFR, uses an equation that depends on creatinine to tell your kidney function. And that creatinine comes from the breakdown or turnover of your own muscles, along with the ingested creatine. So the more muscle you have, or the more creatine you take, it could nudge your creatinine levels up. And it could make your kidney function look worse than what it really is. Typically, this change is modest, but in some people, it could be the difference between labeling them having kidney disease or not. So Cystatin C is a different marker that is less affected by muscle mass. And the most accurate approach is to combine the two, reading them together. Because Cystatin C is not perfect either, as body fat, inflammation, taking steroids, or having thyroid issues can affect its level. But for a muscular creatine-taking patient, it could answer the question. And there's also a practical reason why I care, because I wouldn't ask anybody to raise their protein intake without knowing their kidney function. So I don't want a falsely low number of GFR based on creatine to stop you from doing something that's good for you. And I don't want you to ignore an abnormal GFR or creatine number just saying, oh, I am muscular, I take creatine, because you could have another problem happening affecting your kidney that we could catch earlier, and we don't want to blame it on the creatine only. Tier 3 include the cardiovascular tests that almost never show up on a standard physical, and yet they're the ones that change your risk the most. Remember the test I mentioned at the start, the test that you would need only once in your entire life. It is called lipoprotein A. It's a cholesterol particle that you inherit from your parents. It is genetic, so if you test it once and if it is high, it changes everything about prevention. You might need cholesterol-lowering therapy earlier, or we have to be much more aggressive with our targets. Even if the rest of your cholesterol looks fine. Almost nobody gets this test, and you can't catch risks you've never measured. Now, they're working on developing medications to lower this particle, or lipoprotein A. However, we still don't have long-term data to say if just lowering that number would actually reduce the risk. We have much better data with the LDL cholesterol levels when they're lowered than this one. And the other test in this tier is ApoB, apolipoprotein B. And think of it as a particle count. So every bad cholesterol particle that might build a plaque will carry one ApoB. So instead of measuring just cholesterol, this actually measures the particles in the blood that builds plaques. And here's where it matters. Your LDL could look perfectly at goal, while your ApoB is high. For some people, their LDL is high, their ApoB is high, and others, their LDL is low and their ApoB is still high, and that's a problem. That means you're at higher risk of building a plaque than what the regular cholesterol panel suggests. And this mismatch is usually the culprit, where people with normal-looking cholesterol panels can end up with heart attacks and strokes. And it usually means we might need to be more aggressive with the treatment, so increasing the dose of statins or adding something like ezetimibe, which can assist the statins to perform better, pempedoic acid, or PCSK9 inhibitor to actually bring the particle burden down. One more thing, both lipoprotein A and apolipoprotein B do not require fasting. And for those who might think, why do we even measure the regular cholesterol? Because that gives us a complete picture. We have more data about that LDL trend up, down, how much we lower it after treatment over a very long period of years and decades than we have about these things. It's not just going to give us a diagnosis, but it also helps us figure out if the treatment is working or do we have to make a change. And the reason where I would push to check for lipoprotein A or apolipoprotein B is the same reason I'm careful with all of this. The standard tools to check your cardiovascular risk is usually looking at your risk in the next 10 years. So it's basically answering, do we need to start a statin to prevent a heart attack or stroke in the next 10 years? But it doesn't tell if a 45-year-old is slowly and silently building a plaque that could result in a stroke or a heart attack in their 60s. And that 45-year-old still have 30 or 40 years of cardiovascular life ahead. And that's the time horizon that matters. So let me take a step back and tell you why exactly I care about all of this. I spent years taking care of patients in their 60s, 70s, 80s, and 90s, and that's where I learned something that shaped the way I practice medicine now. The most expensive things in medicine is not a hospitalization. It's losing the ability to walk to the bathroom on your own. So every secreting decision I make comes back to one question. Will catching this early keep helping you stay strong, sharp, and independent in your 80s? Catch kidney disease early, and you may avoid the dialysis and frailty that comes with it. Treat the thyroid, and you've got the energy to keep moving and stay strong. Prevent the heart attack or stroke, and you're there. You're present, you're functional for yourself and for the people who need you. It's not about perfect numbers on a page. It's about staying yourself for as long as possible. And that doesn't start at 70. It starts now in your 40s or 50s or whenever you decide that your future independence is worth investing in now. So this is how you want to be screened, strategically, thoroughly, with someone who's watching your trends over time and keeping up to date with what's what. That's exactly what I built this practice to do. And I've pinned a free checklist in the comments in the description that covers every lab that I order in these 3 tiers, when I order it, and what I'm looking for when I'm ordering it. Download it and bring it to your next physical and ask which of these are you getting. If the answer is a shrug, that's information too. Thank you for watching, and I'll see you in the next one.